Hey y'all, on the same note as last week, or same theme, same flavor, I wanted to talk about options for breast cancer screening, things I recommend, when things don't recommend, at least not individually, things like that. And again, this is something where I'm talking to y'all as like a general audience. I don't know, I'm probably not most of y'all's doctors. I don't know your personal history, family history, other risk factors. So this is just informational. But anywho, I talk about it a lot, so I figured I might as well make a video, and then I can always share the video with future patients should the topic come up again and they want to learn more of what I think about it. So anywho, let's dive in. Let's talk about breast cancer screening. Breast cancer is one of the most common cancers in the US. And thankfully, with research and finding things as early as possible, it is not a life sentence, or death sentence, I should say, for a lot of people. And again, this comes all the way back to what I said in my last video. I'm a primary care doctor. I'm seeing people and diagnosing these things. My job, or my goal, obviously I can't control everything, is to catch things if they're going to come up as early as possible to the best of our ability in the technology and tests we have, so that we can manage them with as little issue as possible. So for example, if someone were to get a breast cancer and they find it ASAP, it's just a little calcification on the mammogram and it gets biopsied and worked up, and it's just that one little spot, and they can do just a little lumpectomy and the margins are great and they don't need any lymph nodes removed or other things, we are like, oh my gosh, praise the Lord, hallelujah, you don't need more. But let's say that same person did not want to undergo screening, at least at that point, or they were really young, or whatever the case may be. Everyone's stories are all very different, and 1 year later we're finding it, but now it's a lot bigger. It's spread different places. Now we're talking, do we need surgery for a mastectomy? Do we need to remove lymph nodes as well, increasing the likelihood of something like lymphedema, which is not fun, uncomfortable, increases risk of skin soft tissue infections like cellulitis, etc. Do we need chemo? Do we need radiation? And when it gets to that point, I'm obviously not driving the car here. We're talking with surgery and oncology, or radiation oncology and stuff like that. But anyway, that's the whole point of me making these videos, is so you know truly if something's going to come up, I want it to be earlier. Now, anytime you go looking for trouble, well, you can find it. So if we go looking for trouble with a mammogram and we find something that is abnormal, and radiology thinks we should do more testing, that an ultrasound or what have you, it ends up being fine, there is more health anxiety temporarily, more of a workup. There are negatives to looking for things a little earlier, but the overwhelming majority of patients that I tell that is a con or side effect of early screening, they're like, oh, totally get it, but I would rather it get worked up and it be fine than it get delayed and pushed farther down the road and something worse ends up happening in the long run. Does that make sense? But anyway, that's just in my headspace how I generally think about it. And people will come in and say data about, oh, getting mammograms at this age versus this age or this frequency isn't showing a lot of improvement or quality of life, or just different things people tell me. And I'll say, okay, let's just say I'm not fact checking any of this, and we just go with, yes, let's just agree with everything you just said. So, this is just a scenario, hypothetical. If that is the case, for the big picture number of people, say this study is 5,000 people. I don't know, I'm just making something up, but a lot of people. And that's the case for a lot of people, but there's still those few sprinkled in between that have an issue that we could have prevented or caught as early as possible. If those are my patients, or if those are my family members, I care, even if it's not the big picture, like greatest trend, population level health numbers. As a primary care doctor, I feel like it's my job to take population health data and public health data and all this and try and tailor it to my patients' personal needs based on their medical history, their risk tolerance, their preferences, all these things. So my patients basically are not just a number to me. I care about their health, their outcomes, their quality of life, their families. So anyways, that's just my ramble. I'm gonna get on with the details now that y'all probably clicked on this video for. But now hopefully y'all are in the same mindset as me. So let's just start with the best thing out there. We got a mammogram. So if you don't know, mammograms are not one and the same. There are 2D mammograms, which is like an X-ray 2D, and there are 3D mammograms. If I had to guess, if you are someone in normal average USA who has decent insurance coverage, government or private sponsor, you are probably nowadays in a resource decently rich area getting a 3D mammogram. You may also, and I'm probably going to pronounce it wrong, see it on there as tomosynthesis. So they are just taking multiple planes, not just a 2D, to get a better and more detailed picture. That is what I'm normally having people do when I get a screening mammogram. But if you're really, again, balling on a budget, and that's the best we can do is a 2D, and it is more cost effective, then I'd say let's go for that. The reasons it is still the best, I know it's uncomfy, and I am not well endowed in that area, so it probably will be uncomfy for me too, is it catches things like DCIS, ductal carcinoma in situ, where they have these little tiny calcifications as like the main finding, as early as better than any other imaging I'm going to talk about, at least at this moment in time. I know in the future we will probably progress and this may change in the future, but for right now that is the case, and it is the modality that's shown with increased or better mortality benefits. I don't know, I'm trying to think how I might want to word it. Better outcomes on morbidity and mortality related to breast cancer. That's just what I'll say there. So on a statistic level basis, on an imaging basis, right now is the best. Now, let's just say you're an average Joe or average Jane or whatever in the situation. Your doctor's probably going to be talking to you about starting a screening around age 40. There are different guidelines that say different things. I have had more than one patient have breast cancer right before 40 years old, or like right as they turned 40, due to my personal experience and other people in my personal life having similar situations. I'm always talking about it at 40, but you may see some other guideline recommendations from some wonderful people that maybe say start at 45. I'm just going to start talking about it at 40, and I have a couple patients that want to hold off. I would not hang your hat on like, oh, I don't have any family history, so I'm never going to get breast cancer. That's just not the case. In fact, on my current patient panel of all the people who have breast cancer, none of them have a family history. So don't think you're immune. Obviously, there's so many factors that go into it, medically, family, obesity, certain substances like alcohol use, things like that. And I'm not saying that to be like, oh, cancer is anyone's fault because they chose to have a drink 5 years ago. No, it's just there's so many factors. And sometimes we're all just humans living on this earth, and we have no or limited control over things. And we can do everything completely right by the books, and we can still get some kind of bad outcome, whether it's breaking our ankle, going on a jog, or getting in a car accident, or getting cancer, autoimmune diagnosis. And that is life. And sometimes we only have control over so much, but we can control a lot of things, like our risk factors for a lot of these chronic conditions and cancers, by eating well, by exercising, getting good sleep, stress management, substance avoidance, and things like that. So anyway, back on topic, mammograms are the best. If you're worried about the discomfort, I would understand. I think some people at different places are a little more gentle than others, and it may also depend on your sensitivity, the size of the breast, things like that. If you're worried about radiation, fear not. These x-rays from a mammogram really are not very robust to be significant over time. The millisievert, whatever, the units they're measured by, the ambient radiation of about 7 or so weeks just walking around outside. You got your cell phone, you got your airplanes, all these things are gonna equal that, and that's just once every 1 to 2 years. I usually try to do once a year, but just think once every 1 to 2 years. So those are my main questions I get asked about mammogram. Cash pay, you might see like $250 or something like that to get a screening mammogram, but most people who have some kind of coverage can get them covered with their insurance, or maybe they can find like a mobile mammography. I mean, breast cancer awareness month's coming up in October, so you might hear or see some programs that help women get free mammograms through some sort of grant or other good, lovely system. But anyway, come October, check and see if you're due for your mammogram. This is your reminder. If you need something additional, maybe you have a higher family risk or personal risk, there's a couple different calculations I'm not going to go into, but they can quantify your risk based on lots of things like periods, pregnancies, family history, when they were diagnosed, like what age, etc. But also if you have dense breast, if you may know that you carry one of the BRCA genes, BRCA genes, for breast cancer, having an increased risk of it, stuff like that, it may behoove you, whenever radiology feels like it's helpful, to get an ultrasound or a breast MRI with your mammogram. Notice I'm saying with the mammogram. If you have a little cyst in your breast and it's new, or it looks suspicious or something, they may recommend doing an ultrasound, or if they need to do an ultrasound guided biopsy, do it with the mammogram. If you have really dense breasts or you're really high risk, like 20% or more, maybe you have the BRCA gene, then they may say to do an MRI with it. Normally people would be like, wow, why don't we just do an MRI? I mean, I would think the same thing. But some of those really early findings from what I was mentioning with the mammogram at this point in time, based on what I've read and heard from really smart people, more so than I in the breast cancer world, it's just some of those earlier findings aren't showing up as well on it. So that's why they're using them together. But ultrasound and breast MRI do not use not contrast, sorry, that's going to jump ahead to my next one. They're not using x-rays or radiation. So you don't have to worry about anything on top of it, but just as an adjunct to make sure we're catching everything. Anyway, I hope that was helpful. That's my main 3 that I'm talking about. Some things you may hear about if you're looking into it on the Googles or AI, whatever you're using nowadays. You can, or you may see contrast enhanced mammogram. That's going to be a little more radiation, obviously the contrast as part of it, but it's going to be more highly detecting things, as well as like a molecular or tagged screen. I don't ever order those, so I'm wondering if that would be more in like a higher risk population, like more in oncology or breast cancer, pre-survivor, survivor, high-risk clinic. We're lucky enough that there's a couple breast centers near us with a couple different hospital systems, and I've heard just great reviews from the people who have sent there. Maybe they're high risk or they just prefer to go there for their breast cancer screenings, like their mammograms. They say the staff are so lovely. So anyway, thank you to all the folks who work there and help take care of our patients and make it as comfortable and seamless as a process for them as it can be. But anywho, I digress. Those I just don't do those a lot. I don't think you're going to see those on a typical screen that we're talking about in the primary care setting. And I'm going to stay in my lane and talk about primary care related things. 2 that I get asked about, or people will bring up that I don't recommend as solely breast cancer screening in the average population. You know, if your mom had gotten a diagnosis of breast cancer at 45, well, yeah, we're going to start getting yours earlier than 40, probably like 35 or so. But anyways, breast self-exams or clinician exams in the office, it's never a bad thing to know what your normal is. So I'm not saying ignore anatomy and what your normal is and just don't worry about it. That's not what I'm saying. I'm just saying don't let it be the only thing that you are doing for breast cancer screening. The studies that have shown human palpation as far as like sensitivity, they pretty much are saying that human palpation feels around the 2 centimeter mark. I think it's a little bit more, like 2.1 or 2.2. So at that point, a cancer's pretty far progressed, and there's probably a lot more we need to dive into on a medical and also maybe surgical side of things. So I just wouldn't rely on human palpation to be that good at catching things as early as possible. Now, in another situation, let's say you're a 29-year-old and you have a lumpy bumpy that feels new, abnormal, firm, non-tender, and you're just like, what the heck? I'm glad you're paying attention. You are someone who wouldn't typically, if you're no family history, no risk otherwise, to be recommended to get a mammogram, but we're going to investigate that, probably starting with an exam in the office as the main thing. We're going to be looking for things like skin changes, stuff like that. So, not something you don't ever do or ignore, just not the only thing for breast cancer screening for the rest of your life. And then the last thing is thermography. Again, this is something mid-2026. This is the data I have, and I'm trying to keep my patients alive and healthy, so I'm going to go with what the data says on what's good. But I think thermography in the future, will we have to reevaluate it and see if it gets better? Yes. Will it pass or surpass mammogram as like the gold standard for breast cancer screening? I don't know. I don't have a crystal ball. At this point in time, no, it does not. It's actually not recommended as a breast cancer screening modality at all. Basically what thermography is has a probe, and it's sensing not ultrasounds like fluid, but more vascularity and heat changes within the tissue. And I've heard of like chiropractor offices and stuff who do it for other reasons outside of breast cancer screening. So anywho, let's just say there's an area of heat or more blood flow to an area. That's an area that may be flagged as more abnormal. And I've never performed one of these, so I can't really tell you the complete ins and outs of how it's performed. But basically what the data shows is if there is an abnormality, this test is more likely to have a false positive, so something that looks abnormal on the test and then ends up being fine. So you get more healthcare anxiety, more workup, time off work, financial implications, stuff like that. And also it catches things later on. So again, trying to catch things as early as possible. If it did catch something, but it's already in stage 3 or 4, that's bad news bears to me. I would rather you get it when it's stage like 1, maybe 2, and we can nip in the bud as soon as possible with the least amount of intervention as possible. So I think, will there be improvements in this kind of modality in the future? I could see it being an area of research. I'm not dogging it and saying it's completely useless 100% of the time. It's never going to get anything right ever. It's just, why do choice number 5 when you have 4 other much better options at a time? I don't know the cost. It probably depends where you go as far as cost effectiveness goes, if that's anything someone's considering at this point. But I'd say just, save up a couple $100 a year, get your mammogram, have some peace of mind, and then go from there. Can't imagine it would be a lot cheaper than that, but I truly could not tell you. But anyway, those are my thoughts on breast cancer screening and the common questions I get from patients or otherwise. And if I'm missing anything, y'all let me know. If you have any other questions that I haven't touched on, maybe I haven't been asked that yet, so I haven't thought about it. Put it in the comments down below. Hope y'all have a great week.